feel free to join, explain, have any questions, and just to try and get it interactive. Kind of a pacemaker's, it's a device usually that carries battery, and with the battery send electrical impulses to the heart. And those electrical impulses either direct contact with the heart or through a wire into the heart kind of connects to the muscle, and with the electrical conduction helps the muscle contract or triggers an action potential, and that's what makes the muscle contracts. The main reason for pacemakers is symptomatic bradycardia. So there are other things, whether to improve conductivity, if someone has chronic tropic incompetence, but the most important thing is the symptomatic bradycardia. So initially, kind of the pacemaker used to be kind of a very big machine in the 1950s, but the latest we have so far are the Micra, which is a leadless pacemaker that is implanted, the whole device is implanted into the RV. Future, we're not sure, there might be patches. There are slightly smaller pacemaker cells, that's only the battery, that sometimes could be implanted into the LV by itself, but still also this is in the future. But so far, the Micra is the smallest one now in commercial use. So if you want to kind of divide the pacemaker into structures, so it has the actual device itself, which we call the pulse generator. The pulse generator, the majority of it, 70 or 80%, is actually a battery, and a smaller portion of it is actually the computer chip that runs the pacemaker. So coming out of the pulse generator, or sometimes in layman terms, we could call it actually the battery, since the majority of the battery. So there are the leads that goes to the heart. So it depends on how many leads you're connecting. So you could have only a single chamber device that has only one lead going either to the atria or ventricle, or you could have a dual chamber device that has two leads going to the atria and ventricle, or you could have a CRT device, which stands for cardiac resynchronization therapy, that has three leads going to the atria, as in this one, or the R and the RV, as in this one, and a third lead going into the atria and then into the coronary sinus behind the LV to give you LV pacing. So we'll talk about the different types of devices, different type of leads. So the leads itself are the kind of that comes out of the device. So usually they could come as passive leads. So at the tip of the lead, instead of having a screw to screw the lead to the heart, it's just kind of very small silicone tines. So it's kind of that anchors the lead in place. So once it goes in, it's harder to dislodge. So we could use either those two types of leads, but the dislodgement rate of the passive leads are slightly higher immediately post-implant, but both leads have good functions. And this is just kind of a close-up of what we call the passive leads, and which is over here, or the active leads, which have a helix or a screw at the tip of it that anchors to the muscle. Okay. So this is the leadless pacemaker, which, because the whole device it's the pacemaker, and at the tip of the device over here, it's where the electrical impulses gets transmitted to the myocardium. So you actually put it into the heart through a sheath, and those are the anchors, if you could see them over here. And this is the Micra on a chest X-ray. Okay, so as we talked about pacemakers, the main indications are symptomatic bradycardia. So any symptoms of bradycardia, dizziness, lightheadedness, fatigue, or even poor exercise tolerance. And bradycardia, which we usually comment on, whether it's a sinus bradycardia or it's AV conduction disease. Okay, so kind of the class 1 indication, as we said, documented symptomatic bradycardia or symptomatic chronotropic incompetence or bradycardia that is related to medication or medical condition. For example, someone needs beta blocker and you can't really stop it. So you might consider bradycardia because of medication that you can't actually stop it. So when we say over here also class 2A, and that's usually for sinus node disease, if the resting heart rate is less than 40, during the patient being awake and not associated with significant symptoms. The second is syncope, when you have some sort of sinus node disease, but you're not really sure of a symptom rhythm correlation. So if you had syncope and then you documented sinus node disease, you think this is most likely the etiology of that. So class 3, if there is no symptoms at all, or if there is symptoms suggestive of bradycardia, but you're able to document it in the absence of bradycardia. So for acquired AV nodal disease, if you were going to say during sinus rhythm, and you had 3rd degree AV block with an escape less than 40. So that's an indication for pacemaker. If you have atrial fibrillation with a pause more than 5 seconds, and there are also other neuromuscular disease that you think that the condition is not going to improve with medical therapy. It's a class 2 indication if you have 3rd degree AV block, but the escape is higher than 40. 2nd degree AV block, type 1 with symptoms, and 1st degree AV block also with symptoms. So, and also 2nd degree AV block type 2 with or without symptoms. So kind of just important here is permanent pacemaker is not indicated for 1st degree AV block or 1st degree AV block without having any symptoms. Usually those are suprahisian block that in the absence considered benign, and in the absence of symptoms, there is no indication for pacemaker. Okay, so just kind of trying to define which is better pacemaker, or kind of try to select the patients or select the pacemaker for patients. So the easiest thing is whether you have a sinus node activity or you don't have a sinus node activity. So if you have a sinus node activity, you would rather put a dual chamber device because you would like to aim for AV synchrony. And if someone has, let us say, atrial fibrillation, so there is no sinus node activity, so single chamber device is more sufficient. So those are kind of the easiest way. So if you're having sinus node, you want to keep AV synchrony, go for dual chamber device. Or if you don't have sinus node function and someone is in persistent atrial fibrillation, a single chamber device would be sufficient. So those are kind of the main things. And then later on, you might consider how to program the pacemaker, that we could move from here and to later on, we'll talk about what is rate response and how do you program it. Okay, so just because pacemaker is a common procedure doesn't mean it's 100% safe procedure. So any procedure you do have a little bit of complication. So the more common things are, so I would usually, when explaining to the patient, start with your pocket. So usually you get either pocket hematoma, pocket, pocket either hematoma or infection. Hematoma could usually happen at the same time of the procedure. The likelihood to increase the hematoma is anticoagulation. And it's usually more common with heparin, fractionated or not fractionated, than the NOACs or vitamin K antagonist. So next is infection. So new devices has less likelihood of infection, and kind of a single chamber device too. So kind of a simple single chamber pacemaker, the infection rate with it is less than 0.5%. But if the number of leads increased, and if it's a redo procedure, for example, for pulse generator replacement or maybe lead dislodgement, the infection rate might increase. So if you're having a patient who had a CRT-D device and he's coming for a pulse generator replacement, the infection rate is higher than just a single new pacemaker implantation. So once you go beyond the pocket, you have the vascular access. So whether you cause any vascular access within the vein itself, or so vein thrombosis or obstruction, they could actually, by mistake, puncture the artery. So it could cause an aneurysm as well. The third is also hemothorax or pneumothorax, because you're puncturing close to the lung and also close to the heart. So, and then once you put the device, also perforation, tamponade, and or problems with the lead itself. So lead dislodgement, most of the, those are most of the complication happens with the devices. So when we consent the patient, we usually tell them there is probably 1 to 2% of having kind of complication from a small hematoma collection up to kind of perforation, tamponade, need for drainage. Okay, so does anyone want to kind of explain or talk about this chest X-ray? Any volunteers? Shall I pick on someone?
Hey, Dr. Yes.
Me, Hamid? Okay.
Yeah. Cool.
Go for it.
So this is an ICD with a single lead. Okay. And
For
the
single lead?
Huh?
Sure. Are you sure it's a single lead?
Yes, I think.
So I'm not sure if you could see it close, but so this is the device.
Okay.
So how many things you're seeing coming out of the device?
So it's not clear for me, but
Okay.
yes.
So if you can't see from the device, then look at the hard shadow itself. So you see this one?
Yes.
Okay.
Placed in the RV.
Do you see something here?
Mm-hmm.
So what is this?
So yes, this is another lead. Yes,
Okay, so
this
we
is
could see one lead over here, the second lead over here.
yes.
So at least there's two leads over here.
Okay.
Okay, so I'll say a third thing. You see those dots?
Mm-hmm.
What are those dots?
These are the, I think it is VSD closure, or not, not sure.
So it seems that they're attached to a wire too, صح?
Mm-hmm.
I'm not sure if you could see it very clear, but there is a wire and there is one dot, maybe one or two dots here, and there's another dot, but there is a wire connecting them.
Okay.
So we're not sure what is this, but what could it be?
I'm not sure. I'm not sure, the Dr. Rose. This, but
So I think this is the LV lead. The LV lead you should see it probably here. So it should be almost parallel to the RV because it goes behind the LV. So, but this is an LV lead that is likely dislodged and it's in the main CS. Okay.
okay.
So
The device.
likely
Yes.
it's a CRT device.
Okay.
Okay. So
Okay. So the dislodgement mean it's not functioning. I mean the device itself.
so so when we say not functioning, we have to be more specific when we say non-functioning. So this is the this is the RV lead. Seems to be in a good position, صح?
Yeah.
Presumably. And this is the atrial lead. Seems to be in a good position. So this lead only the one seems to be dislodged. So it's
Okay.
not in the proper place within a branch of the coronary sinus. So it's actually at the coronary sinus. And if it's going to pace, it's going to capture atria. It's not going to capture ventricle. So this is dislodgement of the lead. So what else could we have? What else is happening here?
About the arrow, I'm not sure if it's pointing toward the pneumothorax or.
Exactly. So you can see here, there's a little bit of calcification, or not calcification, but let us say radio opaque stuff. And you don't see it over here. And you could see kind of a good demarcation, which doesn't follow kind of a rib cage. So here is the first rib, here is the second rib. You can see, you can't see the clavicle very well, but this one demarcation doesn't seem to follow the clavicle. Sorry, not the clavicle, this the shoulder blade. So kind of that makes you think about it. And the other thing, when you look at the apex, you don't see any kind of airspace.
Vascular mark.
Yeah. So kind of, and it's slightly darker comparing both apexes. So this is a pneumothorax. So if you saw this patient post-implant, what are you going to do?
So, approaching this patient, I would put him on oxygen and stabilize him and inform the thoracic surgery regarding the pneumothorax and to inform the EB about this complication.
Exactly. So one is the pneumothorax that you need to address. So the majority of procedure-related pneumothorax kind of just requires higher percentage of oxygen. So it will take few, 3, 4, 5 days, hopefully, to absorb. But rarely that you might need to put a because it's not a tension pneumothorax. So rarely you need to put a chest tube in it.
Yes.
And then the other complication is the dislodgement that you might need to reattempt procedure a few more days, and also change some of the device programming.
Okay.
Next. Okay. So this is a picture of a device or a pocket hematoma. So probably the patient might be on anticoagulation, but usually hematoma arises from the pocket itself. Sometimes if there is kind of an arterial bleed, that might be one of the reasons that might be expanding. So as long as there is no kind of an open wound and drainage, we usually recommend not doing anything because the body will just reabsorb it, but it will take a few times as a big bruise happening. Okay. Someone.
Doctora, regarding the heparin use prior, like if we say the patient on metallic valve and he is planned for BGR or
we actually prefer to keep them on their oral anticoagulation. So metallic valve, usually warfarin. So we usually keep them on warfarin. So the bleeding with warfarin is much lower than the bleeding with kind of bridging to heparin or low molecular weight heparin.
And the acceptable INR usually around
up to 3.
Okay.
And if it's also a pulse generator replacement, we might go slightly above 3. So 3.2, 3.3 is okay because you're not gonna puncture or go into the heart. But up to 3 is usually okay for us.
Thank you.
شفت عبد الرحيم كان رافع يده. Do you want to take
can
this one?
Can I take
or
this
you have
one?
a question? Oh, okay. Sure, go for it.
So we have a lateral chest X-ray with coronal section, chest CT with contrast, arterial phase, and I think the lead is going in the aorta.
Exactly. So it's
arterial axis.
So you might not see it very well here, but it goes here arterially, and then here kind of going, see it's directed more posterior. And as we know, the RV is usually more anterior. So when you see something like this on the lateral, you kind of question what's going on. So RV is more anterior. So that's the trick in the lateral X-ray, just to see the direction of the lead. And this should be a quick. So there is a rim of pericardial effusion. So that could happen because of lead perforation during the implants. Someone wants to say, what is this?
This is can I take this one?
Sure.
This is an X-ray showing a single lead device with tangling of the lead.
Okay, how did this happen?
Possibly pulled out or displaced inferiorly.
So the kind of, you could see the tip of the lead here. So it's kind of weird. There is a loop around the tip of the lead. So I don't know if it's functioning well or no. And over here, as you said, there is some tangling of the proximal part of the lead. But how would this happen, the tangling part?
By dilatation of the pocket itself.
So one of the causes is that there is a big pocket and the device is not stable. It keep on moving and it gets tangled on itself. So that's one explanation.
Or maybe it's been pulled out.
Close enough. So because we suture the pocket, so being pulled out شوية صعبة. This being manipulated on from kind of from on the skin surface. So usually you see it more in elderly that they kind of feel something underneath the skin, so they keep playing with the device. And sometimes they keep on twisting and twirling the device underneath the skin. And that would cause Twiddler syndrome, which actually pulls the lead into the device. So this is what we call Twiddler because of the patient kind of play with the device itself and keep on twisting or twirling the device in the pocket. Okay. Who wants to take this one? صار في أحد تبرع؟ فهد okay, go ahead.
طيب this X-ray for chest X-ray can see a device with single leads. It looks like the lead is turning behind the device. That's okay.
So you're saying a lead behind the device? ما فهمت.
كأنه lead itself, it's turning from behind the device, not going directly to the heart. And the other thing, actually, is it the lead itself? Is it perforating the muscle of the hymen in the heart? It looks like it's more in the heart.
Okay. So just kind of okay. The leads we have, it's not. It comes in certain lengths. So let us say 52 centimeters, 58 centimeters, 62 centimeters, 65 centimeters. They come in different lengths. So usually you try to get the proper length of the lead to the patient's height, but there is almost always lead remaining. So the remaining lead after you implant it, you usually make it as any kind of, you rotate it as a cable, the remaining part of the lead. So it will not be, so you'll be able to keep into the pocket. So all the devices, you're going to see part of the lead behind the device. So that's a standard. لكن في شيء تاني. What is this?
connection between two leads? I'm not sure, صراحة.
So I'm not sure if I could zoom. Just hold on for a second. Okay, Hadi, I zoomed into the picture. Can you see it clearly now?
Yeah, like if another lead and disconnected.
Exactly. So this is another lead got pulled out and it's inside the pocket.
Okay.
I'll just
Are the lead, Doctor, are the material of the lead are elastic? It is retractable or what?
it's
And if
not.
it's
It's a kind of titanium inside the lead itself, kind of the metal part, and it's wrapped with silicone. So it's not kind of not stretchy. No, it has a little bit of a tug to it, but it's not that. It's not stretchy.
Okay.
An example, the same kind of good. It's not, but it's similar to the, let us say, ECG lead that you connect other patients. It's kind of, it's thin, it's metal, it's wrapped with elastic material. Yes. Okay. So this is almost similar. So you could see initially there are two leads. One is going up here and the other one is going down here. The next image is, you could see the tip of one lead here and the second one is around here. And then when you look at the cardiac silhouette, you see none of the leads. And the majority of the leads is actually into the pocket itself. Okay, so some of the skin complication, this is kind of the scar related to the device, and it's kind of a stretch scar. Keloid formation as well. Some also of the complication is the lead entrapment of the one of the tricuspid valve leaflet may cause significant TR. Can someone tell me what this is? Just look at the A image.
injury to the wire, دكتور.
Yes, so probably lead fracture. So you could see, you don't see the opacity kind of goes all the way. There's a break into the wire itself. So this one kind of a lead fracture. So you could sometimes see it in an x-ray. So, and this one over here, you can see there is the silicone material, but if you see in the middle of the picture, kind of the silicone material, it broke. So you could see the metal very clearly underneath that. So this is insulation break. Okay. So I'll skip this one. Okay, so we'll talk about the pacemaker leads. So they can, what we call unipolar or bipolar. So from unipolar leads, let me go to another picture. Okay, so unipolar leads. So the electricity is transmitted from the device into the lead and vice versa. Let us say it's similar to the ECG leads, which is the limp leads. So lead 1, AVL. So those are, sorry, not the chest leads, V1, V2, V3. So you're getting electrical activity transmitting from one area to another area, which is a bigger surface area. So this is kind of from the device into the tip of the lead. So for example, bipolar, no, you have the electricity is transmitted within a very small area, focused area, which we call the tip of the lead, and there is proximal to the tip, which we call the ring. So those are the electrodes that gets transmitted the signal. So for example, over here, if you have, let us say, a high electrical energy somewhere here, let us say, for example, a cell phone closer to the device, so that, let us say, could interfere with the electrical signal transmitted from the device into the lead. But if you're kind of have something close here, usually shouldn't affect the electrical signal generated from the tip to the ring. So this, the bipolar ones are usually more stable. It doesn't have a lot of external kind of transmission, or doesn't get affected a lot externally. So mainly those are the two things. We hardly ever use a unipolar lead anymore, but sometimes we might have to program the lead as unipolar, but we hardly ever, just because of you need a higher energy. There's a lot of external interference and is not as reliable as the bipolar leads. So what does the lead help us? So what is the importance of the lead? So the leads kind of sense the electrical signal coming out of the muscle of the heart, and then paces or transmit the electrical signal into the heart. So the advantages of it, okay, if there is no heart rate, let us say there is bradycardia, so it will wait for the desired amount of time that you want. For example, every second, if there is no heartbeat and if the device didn't sense the electrical signal from the heartbeat, it will deliver an electrical signal that stimulates the myocardium and causes an action potential. So as we said, heart is the sensing. So the same thing when you look at QRS, the device looks at the QRS signal from the heart. So there is an electrical signal coming from the heart. So the device sees that. So the same way you measure the QRS on an ECG, or the voltage of the QRS, the device does that. So measure the voltage of the electrical signal coming from the myocardium. So we usually measure it in millivolts. The normal in the ventricle, because it's a bigger, it's a majority myocardium, it has higher voltage. So ideally you need to have more than 5 millivolts if the lead is in the ventricle. In the atrium, it's smaller portion of the myocardium, so you don't need a high voltage. So 1.5 or 2 is acceptable, that you have a good contact with the myocardium. So do we know فهمنا ايش السنسing now؟ في أحد ما فهمها؟ I'll move on. Yes. Okay. So the things that so once we have the lead in place, we know what is the, let us say, the QRS voltage in the heart and how does the device sees it. So then we program something called sensitivity. So sensitivity is that we want the device to be able to see every QRS signal coming from the heart. So if, let us say, the QRS measurement is 5, so if we program the device to see anything above 2, that means most likely it's going to see every single ventricular signal. So we aim for sensitivity to be about 50% of the R wave. For example, the R wave is 10, so a sensitivity of 5 is actually good. If you want it to be more sensitive, you might lower the number. That means you'll see anything that is above 2, or you could see anything that is above 1 that will be even more sensitive. مفهومة هذه؟ So the sensitivity is that anything above this number, the device is going to see.
So we measure the doctoral amplitude of the R wave on the ECG.
It's not the ECG, but it's a similar concept of measuring the R wave on an ECG. So you measure the R wave from the lead itself, and it's going to give you a reading. So, for example, if you measured the length or the voltage on a QRS on an ECG, we would say this is maybe high voltage because maybe it's more than 10.
Yes.
You're looking for a big signal because that means you're in good contact with the myocardium. So if you see a number that is more than 5 in the ventricle, that's a good number. And then you want the device to see that every single time. So you program the device to see anything above, for example, 2. That means you're going to see almost every QRS. So if you program the device, let us say, to see everything above 10, معناته the device is not that sensitive and it's going to miss the majority of the QRSs.
Okay, I know.
So 1, you need to check exactly what is the device sensing. And 2, you need to set the sensitivity by at least 50% of the R wave. So you'll be able to see the majority of the R wave, so you don't miss beats. So what's the problem if you make the device very, very, very sensitive? Let us say you made it at 0.5, for example. So if you're going to see anything that is above 0.5, so sometimes external noise might give you some electrical signal. You see it on the ECG. So a little bit of noise might give you some signals on the ECG, and those are artifacts. So the same thing can happen with a pacemaker. You don't want it to be very, very, very sensitive because it might pick artifact. And if it picks artifact, it's going to think this is a QRS. And if it sees a QRS, then it's not going to pace. So this is kind of the trick. You need to make it sensitive enough to see every QRS, but not too sensitive, so you will try and avoid artifact. So this is kind of an example. Okay, so let us say the device sees this QRS and measures the amplitude of it, and it says, okay, this is 5 millivolts. So if we program the sensitivity at 6, that anything above 6, the device is not going to see. So if we program it at 6, the device is less sensitive because it's going to miss a majority of the QRSs. Like if we program the device at sensitivity of 3, that means it's going to see the majority of the QRSs since almost all of them are 5 or more. So this is how the device sees it. So this is kind of illustration. And the same thing happens with the atrium, but it's just different numbers. Okay. So we talked about one of the functions of the pacemaker is sensing, seeing what's the R wave, and pacing, which is delivering the electrical impulse. So we'll just go back to this. Okay. So the electrical impulse goes from the device and then gets transmitted if it's a bipolar, goes from the tip and the electricity goes to the ring. So it's only those two areas. So you're delivering an electrical impulse into the myocardium. So that's usually achieved by a specific amount of energy coming from the battery itself. So you don't want to give a high amount of energy because you're going to deplete the battery very quick. So the minimal amount of energy you need is better. And you need an amount of energy that will be able to produce an action potential. So when you put this all together, we call this the pacing. So it's the pulse of energy that is required to capture the myocardium and create the contraction. So this is kind of the pacing. So when we pace, we give this amount of energy, which is measured in volts, and you give it for a duration of time, which we call the pulse duration. So for example, you give 1 volt over 1 millisecond. So this is how you calculate the pacing energy. So it's volts over the amount or the duration, which is to call the pulse duration. So the lower the amount of energy required to capture the myocardium, what we call is the lower the threshold. So the threshold is the minimum amount of energy required. So for example, if you're delivering an energy of 1 volt and you're not creating a myocardial contraction, you increase the energy to 1.5 and you're still not capturing the myocardium, then you increase the energy to 2, and at 2 you're capturing the myocardium. So the threshold is the minimum amount of energy required, which is at this example is actually 2. We'll just ignore this for a minute. انفهمت ايش الثريشولد؟ نشوف اذا في. اوكي. انفهم ايش الثريشولد؟ ولا تبوني ارجع اعيده؟ Okay, okay. So when you're pacing, you're delivering the energy at the same location where the lead is. So if you're pacing from the right ventricle, so you're going to get something similar to a left ventral branch block morphology because you're giving a superior axis and it's negative throughout the chest leads. So this is what RV pacing looks like. Okay, so the threshold that we're talking about usually at implant is usually low. Sometimes it increases after implants and then kind of plateaus. So those are the very old leads, but the newer leads had steroids eluting steroids at the tip of the lead. So to minimize the inflammation at the site of the implants, to minimize kind of the spike in the threshold. Okay. The third thing we do with a pacemaker is the impedance, which is the resistance of the lead itself, because there are metal, there is silicon, and there is some energy going through it. So there is a little bit of resistance. So for example, water has resistance, the kind of any metal thing has resistance, anything has a resistance. So the resistance usually in a closed system, what I mean by closed system is the lead is connected to the device in one area and connected to the myocardium in one area. So usually that's ranging between 500 and some 1500. So that's usually the normal pacing impedance. So if there is a very, so it kind of gives you an idea about the wire itself and the attachment from each area. One is to the device and the other one to the muscle. So if there is a problem with the impedance, it either tells you something's wrong with the wire or something wrong with the connection to the muscle or the device. So what if we have a very low impedance? That means there is minimal resistance. So what could be the problem?
Low battery or broken lead?
Low battery, it's not, has nothing to do with the battery itself. So there is impedance of the device, but I'm talking about the lead impedance. So that means there is very, very, very minimal resistance from the lead itself. So what does the lead contain? We said there is the wires inside and the silicone wrapping outside, the insulation. So if the silicone wrapping outside is broken, then there is nothing to keep the resistance inside. So there's going to be a lot of leak of energy. So there's not going to be a lot of resistance. So there is an insulation break, زي ما كان in this picture over here. So this one we call insulation break. Usually there is very low impedance. And over here we said, so the pacemaker generator screws. So if it's not screwed properly, attached properly to the pacemaker or the ICD, is going to give you a low impedance. And attachment to the muscle. So if it's dislodged, the same thing, that you're not hitting muscle, so there is no resistance. So the impedance is low. And vice versa. So if it's kind of perforated into the, let us say, chest wall or bone or something like that, so you might get a very high impedance. And the same lead, if you actually fracture the lead, so there is no flow to go from one area to another area. So the flow at the proximal part of the lead is going to be very high. So that's going to give you a very high impedance. So we said here insulation break. And lead fracture usually gives you a very high impedance. Okay. Does someone want to tell me this ECG? No volunteers? Shall I pick on someone? It should be straightforward. I'm sorry. Okay, I'll pick on someone. في عندنا مشاري.
Yes, دكتور.
Okay.
السلام عليكم. So this is a 12 lead ECG. The QRS is wide.
Before I go into the QRS, إيش rate rhythm?
Sure. So this is a sinus rhythm, and the rate
this
is
is sinus.
yes, and the rate is around 100. The axis is left axis. The BR interval is not prolonged. And the QRS looks wide, more than 120. I don't see any spikes of pacing, so I cannot say this is a pacing ECG.
Okay, so when you say pacing ECG, you're thinking about
The pacemaker, ECG in the patient.
so what is the okay? So is it RV pacing?
Possible RV pacing, yes, because the white cars indicate that the flow coming from the ventricles or the infra from the infra the nodes, and but if the axis is left, so we cannot say it's RV pacing. It could be the LV pacing more.
Okay. So you mentioned one is if you're having RV pacing or IV apical pacing, you should see the QRS is negative throughout the chest leads. So let me go back. Okay. So usually because it's at the apex, even V5 and V6 are usually negative. So that's usually an RV pacing. Okay.
Doctor, but this is a patient with a pacemaker?
You tell me. So that's the question.
I don't see any pacing spikes. This is for me. This is how can I tell about a pacemaker? So this is I don't see. It's just likely for me to be
so as you said, the morphology of the QRSs and the chest leads is not consistent with RV apical pacing. The second, you don't see pacing spikes. So what would you say this is? I said left axis.
Yes.
There is kind of a small arm, but mostly negative in V1, V2. It's a wide QRS. There is a notch in one AVL. There is absence of Q in V5 and V6. So what is
be
this?
a left bundle branch block, and
Yes.
and it could be a possible also WBW with a notch in the seam.
So there is not a delta. So this is a left bundle branch block. So I brought it just kind of to be able to say this is not likely a pacemaker. So kind of for you to differentiate. So I don't see pacer spikes. The morphology is not typical for pacing, and it's typical for left bundle branch block. Okay. So
دكتورة لمياء ممكن
yes تفضلي.
احنا ليش نقول انه ليفت بندل برانش؟ ما نقول انه البيسنج سنس يعني السنسنج وهو بيسنج ديماند يعني.
So do we know? We don't. So if you don't see any activity, doesn't mean it's there. So okay, But do we have anything to tell us that there is a pacemaker?
ممكن من
I agree
الهيستوري
with you, but
بس
doesn't mean that there is a pacemaker. So we can't comment. That means every ECG is someone who has a pacemaker that it's not working.
اوكي
Is that it?
أيوة،
Yeah,
يعطيك
okay, I
العافية.
agree with you. There could be a pacemaker, but it's not doing anything. It's on demand, as you said. So we don't know. So, and I brought it up here just kind of to show the difference between the left bundle and the pacing morphology. Okay, so when we talk about pacemaker, we said it could be single, dual, 3 different chambers. It could pace, it could sense, and it could increase the rate. So this is the more you're trying, it should kind of شوية complicated, but once you get the nomenclature of it, you might be able to get it. So the first part of it's usually what we usually do is 4. Rarely we do the 5, but we usually do a 4. So since it's a pacemaker, the first letter of the programming is what chamber is it going to pace. The second letter is what chamber is going to sense. And then the third letter, what is it going to respond to sensing? And the fourth one is rate response. So we'll start with the first letter. So if we're having a single chamber device to the ventricle, for example, in someone who has atrial fibrillation with slow ventricular response. So you need a ventricular lead only to increase the ventricular rate. So that is the need for the pacemaker to avoid bradycardia. So the chamber paced, what letter is going to be? A, V, or D? Let me pick someone in senior. Nadir? Yeah, hello. Okay. So as I said, we're going to implant someone who has atrial fibrillation, and we're planning to put only a single chamber device with the lead into the ventricle. So what chamber you're going to pace? Is it going to be atrial, ventricle, or dual?
Sorry again, Doctor, your voice is a bit distant. What's the question?
Okay. Now we're planning to implant a single chamber device into the ventricle. So this is what pacing mode you're gonna set the device at it. So you're gonna pace the atrium, you're gonna pace the ventricle, or you're gonna pace both of them.
We'll choose the V, ventricle.
Okay. So you're mainly gonna pace the ventricle. You don't have an atrial lead, so you're not gonna do anything to the atrium. And since you don't have an atrial lead, then you can't pace both. So you're planning only to pace the ventricle. Okay. And so when does the pacing triggers? So what triggers the pacing in the ventricles? Okay. السؤال اللي يمكن تاني أوضح. So now you're planning to pace the ventricle. How does the device know I'm going to pace now, or I'm going to pace in 2 seconds, or I'm going to pace in 5 seconds? Do you know how the devices works to decide when to pace and when to not?
Between the QRSs, if we have the intervals.
Okay, So هحاول أشرحها بطريقة يمكن okay. So for example إحنا قلنا the device or the pacemaker is going to pace at 60 beats per minute. So
Okay.
first of all, the first one is going to pace the ventricle.
Yes.
So it's going to deliver, we'll start with one impulse. Okay.
Sure.
So, and then if we say 60 seconds, 60 beats per minute, that means every second is going to deliver another impulse. So it's going to pace 1 second, another second, and then another second. So until it sends another signal. For example, if it waited this 1 second and it didn't sense anything, it's going to go back and pace the ventricle.
Yes.
So if it sensed a ventricular signal, it's going to inhibit pacing in the ventricle.
Mm-hmm.
So this is the mode how we do it. So we say VVI.
VVI.
Yes, that means the device
it will
pace the ventricle.
Yes, and it will sense if the patient has its own rhythm. And if the patient has its own rhythm, it will inhibit the device, it will inhibit. But if it's not, they will give another pacing.
So in let us say VVI, the standard is pacing. And the only reason to inhibit the pacing, it's if you sense the ventricular signal. So that's the main thing. So let us say we'll take the opposite. Someone who has let us say, a CRT device. Okay. And when CRT means that we need to pace every single ventricular beat to be able to get by the pacing and improve the heart function, for example. So that means if you're gonna pace both ventricles, that's right?
Yes, we'll take the D.
Okay, but what are you gonna sense?
You will sense the atrium.
Exactly. And the atrium, and once you sense the atrium, what are you gonna do?
Maybe maybe
trigger ventricular pacing. So once you sense an atrial signal, you want to trigger pacing because you want to pace the ventricle all the time. So in CRT devices, the mode is usually
DA.
You're pacing the ventricle. So you're pacing the ventricle, T. Because let us say you're sensing the atrium, and then you're giving yourself some AV delay, and then you're pacing the ventricle because you want to pace all the time. It's not the same as VVI, because if there is an intrinsic, okay, you're gonna just wait for the intrinsic. But in CRT, you want to be paced. So and sometimes, let us say, in someone who doesn't need pacing all the time, for example, intermittent AV block. So let us say Mobitz 2 with Mobitz 2 AV blocks. You're not always having missed beats. So you could actually pace the atrium if there is sinus padding. You could also pace the ventricle. So for example, if your atrium is okay, you're pacing the ventricle. So you're waiting for the atrial beat to kick in before you pace the ventricle. So you have to sense the atrium. And if you sense the atrium, you might want to trigger ventricular. But if there is an intrinsic ventricular, you're going to inhibit the ventricle. So there is a little bit of a we call it, tangles over here. So because you're looking at the atrium and the ventricle in both ways, whether to trigger or inhibit depending on intrinsic activity or no. So that's what the device does. So it's going to do sense both, pace both, and sense both, and inhibit and trigger depending on which signal is there. انفهمت كيف DDD?
Yes.
Because you could either pace the atrium or ventricle in response to the sensing of the atrium or the ventricle, and you could either inhibit pacing if you sensed, or trigger pacing if you sense the other chamber. So in DDD mode, it's always interactive, depending what's happening. So you could inhibit one and trigger the other. So for example, you could inhibit pacing the atria because you have an underlying atrial rhythm, but you triggered ventricular pacing because there is no ventricular signal. So for this, you actually used both. You inhibited pacing in the atrium, but you triggered pacing in the ventricle. So that's why DDD comes interactive here.
Yes. It depends on the presence of the block. So
if there is block, there is, yeah, so mainly what's your desired outcome? So for CRT, we would rather have it paced all the time. For someone who has just a regular pacemaker, you don't need to be paced all the time. You just need it on demand. So that's why programming matters, because it's going to give you the required results, whether 100% pacing or minimal pacing. Okay, so we talked about those three. So the fourth mode of the pacemaker is rate response. So for example, someone has sinus bradycardia and they're having fatigability. So you need to increase their rate. So you put a pacemaker, you put a rate of pacing at 60. But let us say with any regular physical activity, going up the stairs, going for a walk or a jog, they need some extra rate to be able for them to fulfill their activity of daily living. So then you could add an extra features of the pacemaker, which is rate response or rate adaptive. So the device itself would sense that there is an increased activity and the patient need to have an increased heart rate based on this activity. So the sensor that the device is used, which is accelerometer. So accelerometer is usually felt by the device when someone moves his arm during walking. So your arm swinging usually moves part of the chest that by itself gets transmitted to the device, and that's when the device knows that there is some activity, so it will start increasing its demand heart rate. The second thing is the minute ventilation. So the lead itself might be able to sense the intracardiac change in the intrathoracic impedance. Or so that results from kind of increased respiratory rate, and that results from increased activity. So if someone is going up and down the stairs, their breathing is heavier, they're a little bit more tachypnic. And with the sensor, the device would be able to assess the minute ventilation, and the increase in that indicates an increased activity. The same thing also that the lead might be able to measure the QT intervals. And usually with increased activity, there is shortening of the QT interval, and then the device would know to increase the heart rate. But the majority of the sensors in the device is the accelerometer. Okay. Someone wants to pick on or take this one? MA? MA? Right, right. Okay, me next في مجاهد. مجاهد.
Can I try it, Doctor?
Sure, go for it.
Okay. So this ECG, there is spike before each QRS. Okay, so I think it's sensing ventricular.
Sensing ventricle.
Mhm.
second
I-
wave بدون سبايك فهو sensing.
I'm thinking, yes. Yes, I'm thinking it is sensing, yes, ventricular. I think this. So V. And it's conducted every after each spike. But in the first two beats, or the second beats only, there is no spike. I don't know how to explain it.
Well, ignore this one for a while. So the rest of it is
Spike and conducted, yes.
okay. So, and where is the device? Where is the lead?
Right.
It's after the cure, the spike.
Okay. So kind of to gather your thoughts. So this is ECG with, is it single or dual pacemaker?
I think it is single.
Why do you think it is single?
Okay. I'm not sure. I'm not sure if it's single or dual.
Okay. So at
Okay.
least there is a ventricular lead, صح?
Yes.
Okay. إذا كان في atrial lead, what does the atrial lead do?
P wave.
It will present as a P wave before the QRS.
So either it's gonna pace the atrium or sense the atrium, صح?
Yes.
Okay. Do we have anything suggestive of atrial pacing?
No.
Okay. So and then sensing the atria. So could we see any P waves?
No, I cannot. I don't. No, it's not recognizable.
So there is some atrial activity, لكن I'm not sure if it's really a true P wave. And you could see something here, you could see something here, nothing here. You could see something inverted here, you could see something upright. And it doesn't seem to come on a regular basis. صح?
Yes.
Okay, so
Different.
let us say if the device is not seeing regular P wave.
So
any,
it's not. It's ignoring the atrial activity.
okay. لأنه if it's sensing a regular P wave, إيش المفروض يكون after each P wave?
The spike, sir.
The pace QRS.
Yes.
So at least we don't have any evidence of atrial pacing. We don't have any evidence of atrial sensing. So I can't comment if there is an atrial lead or not. So to my best of my knowledge, this is only a single chamber device. That's to the best of my knowledge.
Okay.
Okay. So احنا قلنا pacemaker senses and pacing, صح?
Yes.
Is it pacing properly?
Yes, it's spacing properly, I think.
So what does pacing properly means بالنسبة لي?
After each spike of pacemaker, there is a QRS.
Okay, so it's capturing every spike or every pacing, there is capture.
Yes.
So it's capturing every single time. Okay.
Okay.
خلينا نرجع لهذه مرة ثانية.
Except from that single.
خلينا نرجع لهذه. Okay. So over here you see the pacing spike. خلينا نرجع للرhythm strip. Over here you see the pacing spike. It's mostly below the isoelectric line, صح? Over
Yes.
here you see it above. Over here you see it above and below. It goes below and then turns out to be above. But this is just a little bit of variation where the pacing spike manifests itself. But if you go here, صح, you can see it. لكن what makes you think this is paced?
It comes in a regular.
So exactly at the same rate as the other ones.
Yes.
Okay. The second thing, what makes you think this is paced?
The shape also of the QRS is the same as others.
So yeah, the morphology. So if you follow, and you probably want to compare it on the same. So in lead 2, before and after, they're the same. Lead 1, although it's a small QRS, but it looks the same. Lead 3, before and after, looks the same. So صح, you don't see the pacer spike, but it might be because of the variation that's actually seeing in the baseline. So you don't see it exactly the same position every single time. I think this is still paced. Could we comment on the sensing of the RV lead?
So also the sensing, I think, is appropriate.
So we don't know. So for us to comment on the sensing, there should be an escape something, an escape ventricular beat, so the device will inhibit pacing. And then we could actually say, okay, the device sensed this QRS. Like in the majority, all of the beats here are paced. So I can't comment on the pacing or in the pacemaker sensing. I could only comment on the pacing. So it's pacing and capturing properly. I can't comment on the sensing.
Okay.
You would think, yes, but I can't. Let's see what's next. Who wants to take this one?
Can I take it?
Sure.
Yes. So this is a 12 lead ECG. Showing paced rhythm in, before each ventricular beat, except two paced rhythm, they are not delivered properly.
So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So which one are you talking about?
Number 6.
1, 2, 3, 4, 5, 6. Okay. So what's happening here?
So it is a spiking, but it doesn't show a QRS, the same morphology as the previous one that's been delivered. And the second one is a different morphology of QRS complex that is not paced.
Okay. So you're saying, okay, this is paced.
Yes.
There is a pacing spike, but what is the underlying rhythm?
Right bundle.
Okay, but right bundle is sure. So this one looks very similar to this one. So,
Yes.
okay. Although there is a pacing spike here. So you're saying this is paced or not paced?
It
This
is
is
paced,
spiky.
but there is the spike,
Okay.
but it doesn't show the morphology of a spiked QRS complex. So it's not captured.
This is not paced. It is coming in the middle of the QRS. It is not before the P wave, neither before the QRS. So it's not, there's no enough time to deliver the complex. So, so this is spike just happened in the middle of the intrinsic rhythm, maybe. So I think this is a failure. This is not best rhythm. This is this spike. I think it's a failure to not to capture. I think it's failure to sense.
Okay. So actually, so if you look at it, there is maybe once the QRS starts and there is a pacing spike. So it's very, very, very close to the initial part of the QRS. So it's, I think, less than, so it's less than one small square between the spike and the beginning of the QRS. And one small square is 40 milliseconds. But it might be even less if we actually go into the intracardiac tracing and measure it. So sometimes the device doesn't actually see it and might give the spike. So we call this pseudo fusion because it's not fused. It's not a fusion between a paced and an intrinsic, but there is a pacing spike there. But this is the intrinsic. So we call that a pseudo fusion. So what could cause that? Whether either at the QRS happening at the same, almost the same time as the pacing spike. So the pacing doesn't have time to transmit and the intrinsic QRS takes over. Or sometimes we call this safety pacing. So for example, the device is not sure if this is an intrinsic QRS or no. So it would deliver a spike or delivering a pacing spike just to avoid
Okay.
to avoid a dropped QRS.
So you do agree, Doctora, this is intrinsic QRS,
This is an
intrinsic
intrinsic.
rhythm, and this is a spike is too
So, but it
close to
doesn't
the
mean-
QRS to be delivered.
Yeah, but it doesn't mean
Yeah.
there is a failure here. So this could
Okay.
be a normal phenomena from the device. So
Yeah,
it doesn't have
the
to be
Zodo.
failure to sense or failure to capture. So it
Okay,
could be
okay,
part of a
got it.
safety measures actually from the device.
Sure.
Okay, so I'll go just one more. Okay. So could we comment on the capture?
It's different. It showed a different amplitude.
But that doesn't does that add a pacing spike?
Yes.
It doesn't matter. So it depends on one, what type of leads you're using, a unipolar or bipolar, and also depends how the chest wall is, how big the distance between the electrodes and the chest wall or between the pacemaker. So the amplitude of the pacing spike is not that important.
What about the negative and positive deflection? So like in the V5 longest trip, it started as a negative, and then in the last three beats got positive.
No, it doesn't matter. This is most likely a unipolar lead. And that's why you see the pacer spike very high. The pacer spike direction doesn't affect the functionality of the pacemaker. So إيش سوينا إحنا in the previous? So is this a single or a dual?
I think it is single because it is before the QRS complex. There is no P wave that is.
So we don't see any atrial activity, whether
Yes.
paced or sensed atrial activity. So if there is an atrial lead, at least it's not presenting itself here as sensing or causing the QRS to track. So most likely this is a single chamber device. So is it pacing properly or not?
It is pacing properly.
Okay, so it's pacing and capturing. Is it sensing properly?
Sensing.
There is, yes, it is
Robert.
sensing most of the beats except for this one.
So
Which you
this
mentioned
one is
as a
probably
normal
could be a safety pacing or normal phenomenon. So, but this one,
Sensing.
so I was able to sense it. It inhibited pacing, and it waited for the appropriate amount of time between the QRSs to deliver the next impulse. So at least this is a single chamber pacemaker with normal pacing and capturing and normal sensing.
Doctor, may I ask,
Okay.
how do we tell it is a single chamber pacing?
Because we يعني زي example اللي قبلها إذا كان عندنا atrial lead. Okay. So a lead with إذا كان عندنا atrial lead. So we said the pacemaker either paces or senses. خلينا نقول الpacemaker atrial lead. Is it pacing an atrial? Or do you see any paced atrial signal?
So in here there is no signal from the atrial.
Okay, so at least for now we excluded that there is a paced atrial signal, صح?
Yes, but in the intrinsic lead, I think there is a P wave, small P wave. I'm not sure. So
أنا صراحة I can't see it. I see something here.
Yes,
but this is the only thing I see. I don't see anything in the Gita rhythm strip.
Okay.
Did you see something؟
No,
لأنه
no,
صراحة
only in
أنا I
this,
can't. Yeah.
only in this
Okay.
intrinsic, yes.
إذا كان عندنا intrinsic atrial activity خلينا نقول sinus node with complete heart block. إذا كان في atrial lead معناته ال atrial lead should sense the P wave and then the P wave should trigger the QRS spacing صح ولا لا؟
Yes.
Normally إذا كان عندك complete heart block you have a pacemaker that follows the P wave. فأنت you should look for a P wave before the QRSs. إذا ما في P wave معناته you're not sensing any atrial signal that triggers the ventricular pacing.
Mm-hmm.
Did you get it?
Yes.
I think yes.
Because there is no, I would say there is no atrial pacing. إذا كان في atrial signal, you would think that the pacemaker should track the atrial signal. فإذا كانت ما في tracking معناته there is no atrial signal that you can see.
So there will be a P wave if it is atrial sensing.
If it's atrial sensing, you would think that the device is gonna follow the normal physiological A, V, A, V, A, V. So if you don't see any A and you could only see V, معناته the device also is not seeing any A. If the device is not seeing any A, معناته either there is no atrial lead or there is no A all the time. فهمت؟
إن شاء الله. It need to be reviewed يعني later on. بس I think for now it's clear إن شاء الله.
And let me also عندي دقيقة. I think I have something with a dual. 1 second. Okay. So أحد يبغى ياخذ هذه؟
دكتورة أنا باخذها.
Okay.
في سبايك، تو سبايك قبل البي وقبل الكيو ار اس كومبلكس. كل الويف فيها سبايك للاتريوم والفنتريكل، فشكله دول ماني شايفه انه في سنسنج يعني.
So single or dual chamber device?
دول.
Okay. So the atrial lead, could we comment on pacing?
بيسنج يا دكتورة بكل ال.
Okay. So we have a P wave here. We have a spike here and there is a P wave. We have a spike here and then P wave, spike, P wave. And you can see that along the rhythm structure. So each atrial spike, okay, at least each first spike is followed by a P wave. So there is
spike صح spike للكيو ار اف كيو ار اس كمان.
So yeah, for the atrial, so there is pacing and capturing. So there is normal capture or good capture. And what about sensing of the atria?
ماني شايفة أي يعني ما في.
So we don't
ما
have
في أي
any
normal.
intrinsic atrial activity to be able to comment on atrial sensing. So the next, the ventricular lead.
Pacing وكابتشر برضه ما في ما في normal wave عشان السنسينج.
Okay, so this is a dual chamber device with seems to be normal pacing and capturing for both atria and ventricle, but unfortunately we can't comment on the sensing in both leads. So let's kind of go back to the previous ECG and just ignore the atrial spike. So is a Canet dual chamber device and it's sensing the atrium, you're not going to see the atrial spike. And you would see P by then QRS paced, then intrinsic P, and then followed by a paced QRS. So that's how you're going to see if there is intrinsic atrial activity with paced QRS. An example of complete heart block. I'm trying to find it, but I'm only at it. So it's going to look similar to this, but without the atrial spike. And with that, we should know that we have an atrial lead.
So we use these the atrial sensing. We use it in complete heart block.
So anything that you would actually need to keep AB synchrony. So, for example, complete heart block or any AV block. So you want to maintain AV synchrony. So you use a dual chamber to be able to maintain the AV synchrony.
دكتورة لمياء معلش سؤال، هو نفس نظام ال VOO اللي بنعمله اللي قبل الأوبريشن نفس الفكرة؟
You tell me. So خلينا نرجع للجدول and you tell me what VOO does.
إنه يا دكتورة بيكون بيسنج بدون ما في inhibition ولا أي شيء، بيسنج على طول، ما في سينسينج، هو بيسنج على طول نفس اللي بنعمله قبل الأوبريشن.
Okay. So when we say V, we're pacing the ventricle and you're sensing, you're sensing nothing. And
أيوة ما
your
في
response to sensing is O. So you're pacing the ventricle and you ignore, you're saying VOO صح؟ ولا DOO؟
أنا ما أدري هو ينفع نقول DOO يعني ما أدري صراحة.
You tell me. So that means you're pacing, for example, atrium or ventricle, and you're ignoring any sensed activity because you're not looking at the sense and your response to sensing is zero. So you're only pacing the ventricle. So when do you do that? You said for pre-procedure operatively? ليش؟
دكتورة العمليات اللي فيها كوتري وكذا عشان ما يصير شوك لأنه سنسيتيف
Okay.
فما أعرف هو ينفع نقول DOO ولا ما أدري الصراحة.
So we'll go for the concept and then we'll see how we could program it. So the idea you want to ignore any sensing to avoid some problems. So if you want to pace the ventricle على طول and ignore the sensing. فمعناته if there is any noise coming, you're going to ignore it. Any intrinsic heartbeat, you're going to ignore it. But this usually happens if you're, as you said, using cautery. لكن a cautery has to be closer to the device. So within 6 inches of the device might sense kind of small electrical signal, and the device might think this is an underlying atrial signal or ventricular signal and might inhibit pacing. So you're ordering the device to pace all the time while ignoring any signal. So as you said during the surgery. So this is only for pacing. That's my point. So you're going to pace all the time. So those are the people that you are pacer dependent, and you know that there might be a surrounding noise around them. So someone عنده sinus bradycardia or chronotropic incompetence. So his resting heart rate is in the 50s. He usually uses the pacemaker when he does his activities, so going up the stairs or going for a walk or anything. So let us say he uses his pacemaker 20 or 30% of the time. Do you need to program him as VOO or DOO when he goes for surgery?
دكتور عفوا إيش سؤالك؟
سؤالي, if someone is pacing 20% of the time, mainly to give them a higher rate response. So usually at rest, they have their intrinsic heart rate. They don't require the pacemaker. So would you reprogram them before going to surgery? So you were saying we program them when they go to the surgery عشان في noise ممكن يطلع من الcautery, and to avoid having improper sensing and loss of pacing and bradycardia. صح? Okay. So if someone, his underlying heart rate is in the 50s, who's not requiring the pacemaker all the time, they usually require the pacemaker mainly with activities. Do we need to reprogram the pacemaker before they go to surgery?
أظن لا.
عشان
مش depend على البيسنج ما أدري.
Exactly. So they're not pacer dependent. So دحين he's now not using the pacemaker. So even if they use cautery, it's not going to affect the pacemaker because he's not using it. Is that my point?
أيوة يا دكتور يعطيك العافية.
Okay. So when we say DOO, that means we're pacing the atrium and ventricle all the time and ignoring any underlying signal. So the same thing with the VOO. So this is for pacing. You were saying about shocks?
دكتورة that's complicated.
This is هي دخلتنا موضوع تاني شوية complicated. If you're talking about بس عشان هذه حتكون آخر شيء خلاص we'll call it a day. So if you're talking about shocks, the pacer function or the pacing is different than the shock algorithm. So even if you pace VOO, that means it's not gonna inhibit pacing إذا كان في noise. لكن the device is still gonna see any noise. Changing the pacing modality in a defibrillator doesn't inhibit the shock. But you have to turn off the defibrillation portion of it, regardless what the pacer function of the device is. Okay? So the defibrillator had defibrillation and has pacing. But if you want to avoid inappropriate shock during the procedure, we're going to have to change the shock setting not the pacing setting. Pacing is only for pacing. فهمت؟
صح أنا شكلي لخبطت.
Yeah. احنا yes, we change the pacing setting if they're going for a procedure. If they have a defibrillation, there's an extra step you have to do for the defibrillator. Like, and you still have to adjust the pacing setting depending on their dependency or the pacing required. If they're not dependent, then you don't need to change it. If they're dependent, then you need to change it depending on their procedure risk. So if their cotter is very close to their device, yes, we would change it.
Okay.
We'll call it a day. بس بالنسبة للأشياء هذه هل في أي أسئلة بالنسبة لليوم؟
دكتورة لميا عندي تو كويستشن إذا ما عليك.
تفضل.
دكتورة فيها بالنسبة في سؤال تكنيكال شوية. الليدلس بيس ميكر is it bipolar or unipolar?
Yes, it's bipolar.
So the anode and cathode it will be in the capsule itself or?
So it's just around the أرجع So it's both at the tip of the pacemaker.
So Doctora, if it's if the battery depleted, you will remove it, put another one or a conventional pacemaker?
So unfortunately, since the whole device goes into the myocardium, after 6 months and up to 12 months, the device gets endothelialized. So even if you open the myocardium, if you open the heart, you can't actually see it. So to take it out after 1 year is almost always impossible. But you could sometimes take it out soon after. شايف إن there is a small يعني ممكن تحط عليها زي إيش اسمه؟ Not a hook, but I forgot what is it called. Just to hold the tip of the device and pull it out. Like, and once it gets endothelialized, everything gets covered, so you can't get over here. So after a year, if you need to put a device, you would actually have to put a whole new one in.
Okay, Doctora, the other question about the indication. So out of the class 1 indications, some patients having, for example, atrial fibrillation with long pause, but he has symptoms typical for vasovagal. So how to approach it? With the tilt-table or just proceed directly putting a pacemaker?
والله إذا هو long pause of 5 or more seconds, I would actually go ahead and put a pacemaker. Because there is this, although it's not causing any symptoms right now, but it's a high risk. So I'd put a pacemaker and then I would treat the vasovagal episode on itself.
طب اوكي دكتورة في يعني few patient with HOCM having high gradient but after sequential pacing the gradient getting better يعني. Is this a per se is an indication for pacemaker and HOCM?
So usually we don't, yes, you could. So HOCM by itself, device therapy and HOCM is on its own. But usually if you're gonna implant a device in HOCM, you might as well implant an ICD. Because if there is enough gradient to cause obstruction and symptoms, that by itself might be also by itself an indication for defibrillator. Because in HOCM for defibrillator, you need either syncope, you're not able to get enough or hypotension during exercise, septal thickness of more than 3 centimeters. So if you're contemplating device therapy for obstruction, you might as well put an ICD. And usually most of our patients that we have to put an ICD in, if they have an element of LVT obstruction, we prefer putting a dual chamber device to create the desynchrony and minimize the obstruction.
But Doctora, the mechanism from EB point of view, reducing the gradient, is the rhythm itself?
It's by causing desynchrony. So what happens in pacing itself? So you actually capture the right side of the heart first, and then the electrical signal gets transmitted within the myocardium into the left side. And that's why you have the wide QRS, because not the whole ventricle is contracting at the same time. And when you see an echo, you would see that paradoxical septal movement that's usually triggered by pacing. And that's what you actually want when you pace the RV and HOCM. You need the septum to be moved towards the RV instead of into the LV. So you cause this paradoxical septal movement. And with that, you hopefully relieve some of the obstruction in the LVOT.
Thank you, Doctor.